Hi, welcome to Let's Do Digital and Ask Someone in Digital online series. I'm Dr. Emma Davis. I'm a GP with a 6-year history in digital healthcare and a background around the NHS. Let's Do Digital is bringing this challenging titled talk called Are We Ready to Erode Patient Trust in Streamlined Digital Healthcare? To help us learn all about cybersecurity. This is Geoff Revill, part of the Let's Do Digital network. Panel of experts and a founder of a relatively new company, Safe Space One. They won an award for Innovate UK last year. Based in Devon, his team specialise in healthcare-centred, patient-centred healthcare platforms. He's driven by his prior healthcare work and life experiences to make sharing healthcare data transparent and accountable. This talk is created around the concept of cybersecurity and trust between patients, clinicians, and systems. But I'll now bring in Geoff to tell us more. If you have any questions, please feel free to add them to the chat and we'll bring them in at the end of the talk.
Brilliant. Thank you very much, Emma. Is my screen being shared? Yes, it is. There it is. Excellent. So yes, confidentiality, trust, and usability. These are all balancing acts that we have to undertake when building digital systems. And what we're going to do today is to delve into those terms and issues and balancing and walk that tightrope as we try and understand better about how to build such systems and actually perhaps challenge some of the default ways of working a little bit. So, just a quick bit about Safe Space One. Yeah, we are very patient-centered as a digital healthcare platform provider, and our focus is the consultation itself, and particularly in the context of long-term treatment processes. So that's the area that we've historically looked at and are building a platform around. So trust. Let's talk a little bit about that. The good news is, from a clinician point of view, according to the Nuffield Trust, that just opening the door and meeting a doctor, you'll get their trust around about 80% of the time, which basically means they'll assume you have ability and expertise. They'll assume you are benevolent or have their best interests at heart. And importantly, they have confidence in your clinical and clinician integrity. So the interesting question you have to ask yourself is, do patients trust the integrity of the digital health solutions? Because when that becomes the intermediary, that's the thing that we also have to meet the same standards as the clinician. So there's an assumption, an underlying assumption in the way we build digital systems at the moment, and that is that we assume the integrity of the IT staff. Now, we may, in good organizations, ensure that they are trained, given some ethics guidance that's contextual to the clinical context of the systems that they're operating in, or maybe they don't. I think it's certainly a question to ask yourself. But are these standards the same as clinicians? And the short answer to that is no, they're not. They tend to be focused around cybersecurity as kind of the focal point. Ethics don't necessarily come into it. They influence it, but they're not held to account, and they're not trained to be integral in the same way as a clinician is. They don't go through 7 years of training around these kinds of issues. But ultimately, patients, I would argue, probably assume that it is, because to them, it's almost transparent that they're using digital in this communication medium. So there's an underlying assumption that's preeminent in the system that, that integrity is there. And I think that's an interesting thing to think about and perhaps challenge. Challenge it because the assumption or the desire of people is of 87% of people, is that they can trust both the data and the ethics of those managing it, while fully understanding that in most cases, that's not the reality of the way digital systems are done. Obviously, social media is right at the far end of the spectrum, and it's well known that they are not people who are, shall we say, held to a high standard of integrity. And so they're very low on the trust spectrum. The NHS, right up there above banks, and even friends and family, which I found interesting, at 59%. But the bad news is that means 41% don't. And that's a big gap between that and the 87% desire. So there's a big gap for us all to fill. But I think you need to drill down on that data and understand the patient and their attitudes to their data use in the trust context. And this is a study that came out at the end of last year. Very useful in the study, lots of detail on it. But I just took this bit element out and just added my own words here, that essentially 21% are looking at or start with the assumption of total trust, which is really nice. But then it starts to degrade. There's an assumed level of trust, mostly because they don't really understand. There's a balanced set of trust, which says, I know that I shouldn't and couldn't fully trust you, but I'm going to because I have to. And then they move down to concerned distrust, is that, I don't feel in control of my own information. And then down to assumed is that, I don't understand why they need it in the first place. And then you get to the absolute naysayers who just don't trust institutions generally. That spectrum of trust, or shall we say starting point of trust in digital systems, I think it's really interesting to understand and think about, because essentially a huge percentage of people start with a level of distrust around your systems. But at the positive end of the spectrum, the Health Foundation last year published a report that basically people think technology does improve things in terms of quality of health and are supportive of its many possible uses. But not all technologies are equally liked. And I brought this bit out of that study, which I thought was really interesting, that those that empower people, in this case patients, to manage their health and better connect with the NHS seem to be more popular. And those two elements are going to come into the discussion as we delve a little bit deeper into that whole trust concept. We also need to just recognize for a moment that trust in digital is fundamentally different to interpersonal trust, which is generally recoverable after a failure when a mistake is made by a person. But if it's made by a machine, the loss of confidence is significant and very often permanent or long term. So when you're thinking about that, it really means that when digital is the intermediary for healthcare communication, then trust in it and the integrity of the digital service itself becomes as important as trust in the clinician. So when I stated earlier on about, are the IT service people held to the same standards as clinicians, and they're probably not, then clearly we've already got a gap, and we need to think about that gap. So let's go back to the patient again, and where do they start in terms of trust? And there's sort of two norms of trust that they all have had experience around. One is social, which is all about recognizing if I share information with somebody that makes me vulnerable, that won't be exploited. That's kind of the sort of central point of that. Whereas business, they also know that trust is different, right? It's that the value exchange is fair and equitable. So that's nice. They also expect that the loss of trust drives an equivalent and proportional consequence on both parties, which is why most businesses struggle to reach 100% trustworthiness, right? Because most people know that really that consequence doesn't fall fairly on both parties, hardly ever. It entirely falls or largely falls on the customer, and the organization has all the power to protect themselves from such consequences and work very hard to do so. So that's the reality of the world, and that kind of colors people's initial perspectives. So let's talk about digital and trust in digital systems and what I've generally seen. So the good news is the World Health Organization did a nice job of really summarizing data management in trust principles, and I really like these principles. They work really well. But I think I'd like to start with the point that the word trust is an absolute word, and there is no absolute in digital. I think anyone in digital would know that. So nothing is absolutely secure, so nothing is absolutely trustworthy. So the best thing we can do is try to be worthy of that trust. And the tools for that job are these three elements: transparency, control, and accountability. Now, I see in most systems development a fairly high degree of transparency in those systems about the data use, the access, sometimes confidentiality. Sometimes they'll be fairly open about their security methods and methodologies. And certainly to the degree of privacy that they claim to offer you, which is all well and good. So most businesses and organizations tend to think trust in the transparency term. We'll be very open with you and you can trust us, right? The idea being that, we're accountable to the law. So because we're accountable to the law, that's all right. Except that, in my view, accountability, when you read the principles in detail, it's not to the law at all. It's to the individual that you're serving. And the degree to which we empower people to hold us to account is really interesting in a system design. We have to assume that we're going to fail. What are we going to do to allow people to hold us to account in that context? I think we need to do more work in that area. And then there's control, right? That's where it's control by the customer, patient, to be empowered to exercise appropriate rights. And again, the law, to some extent, GDPR and similar, starts to enable people to do that. The vast majority of people, though, in reality, don't understand their rights, certainly don't understand how to exercise them. And even if they did, probably are not financially in a position to do so. So given that control is a key building block of trust and trustworthiness, what do we do in our systems to try and bring that element to bear and empower the patient? And again, I don't think we do enough. I've talked about privacy and confidentiality. I just want to make sure we set a baseline on what I'm talking about here, so the subsequent discussions are clear. There is a very big distinct difference between confidentiality and privacy. Privacy is really fundamentally about the assurance that the information shared is used for a particular purpose that I understand, right, as a patient. And if I don't understand it, then that's problematic, and that's a breach of privacy if it's used for some other purpose that I didn't understand, even if you put it in the fine print of your legal contract. Confidentiality, on the other hand, is very different. It's about assurance that only those that need access to my information are granted it. So that'll be my clinician I'm engaging with, anybody they think is appropriate to share it with in order to provide the support that I need. But in the patient's head, that probably doesn't include the whole IT department, who digitally and technically probably does have full access to everything. So we have to think about that kind of thing as a challenge. So I like to bring these two things together and think about a digital security architecture design objective when we're building such systems. And that is very simply that what is shared in confidence is secured by access by me, for access by me and the persons I share with, and kept private within the bounds of my or our purpose for sharing. So confidentiality can extend as long as that's within the privacy boundaries that we've defined and that the patient understands. And I think if you tie these two things together properly, you'll approach building your digital system appropriately. Now, let's take a step back. Health data, we all know it's worth a lot of money. I just think it's worth quantifying it a little bit. First of all, there's more health data coming in mental health apps alone than there is user activity on online banking systems today. So that just tells you the wealth and quantity of data out there. But on the other side of that, as an ethical hacker has highlighted, that that type of personal data is more valuable than a credit card. So they believe the dark web community believes that information has more utility and value and return on investment from their point of view than your credit card. And I think that's really important to understand. How did the breaches occur? Because if we're looking at, let's touch on that cybersecurity bit for a moment. The UK government, DCIT, just announced the cyber breach report earlier this year. And what they highlight is that 84% of breaches are down to phishing. And phishing, in very simple terms, is an external privilege escalation attack based on user access rights. So it's about me getting access rights as an external individual based upon somebody else's access rights as an internal individual. And it's the most common first step to a ransom or successful ransomware attack. I think it's also worth noting that there's also a 44% increase in access rights abuse. So the more people we give access to a system, the more likely they are to abuse it. And there's an example here that just came out just in the last couple of weeks. And this was a surgeon at an NHS hospital, trainee surgeon, abused his ability to access information, and unfortunately 2 women were raped as a consequence. Now, I would say that that's the least likely to happen in that sort of environment because there is an IT team, looking over this sort of stuff. But the fact is, it's still going to happen. So we need to keep an eye out for that kind of abuse as well, because the more access rights we enable, the more risk that we're generating in our systems. So, principled first step to phishing mitigation. Now, when I've looked at trust in the past, I've always said that the most important first step that comes out of the GDPR principles, for example, is data minimization. If you minimize the data that you have, you minimize how much you move it, you minimize the number of people you share it with, then you are doing the best you can on the behalf of the personal data, the individual affected by that personal data. However, in health, that doesn't kind of work in quite the same way, because actually, as far as that health information is concerned, we want to maximize it, right? We want to collect as much as we can. And given the nature of the types of breaches that we're seeing, I would say that we need to think a little bit differently about sort of primary principles of operation, and think more about rights of access as a primary issue to consider when building our systems. Now, just going back to ransomware, by the way, just make sure you do your regular backups, make sure those backups are offline, and for God's sakes, please test the recovery ability from those backups. So let's touch in on a worked example here. So this is information that we've got by speaking to a number of GPs and also trust managers. And essentially the trust model that they operate in a GP surgery is a trust but verify model. Okay. Now, what that basically means is that they are giving access to, well, pretty much all of the staff who are, the back office supporters of the clinical front office team, so that they can, support the patient, support the organization at the same time. So that's kind of sort of good from an organizational efficiency point of view. You might argue it's good from a patient safety point of view. You might argue the opposite. It's certainly worth something to take a hard look at and say, should that be the way things are done? Now, the trust but verify model gets interesting because, of course, the trust component assumes a high quality verify component. But what we see in practice in GPs is that in the main, the person, they don't have IT managers very rarely, unless they're a very large practice, which is about 1 in 10 of them. They will, the other 9 in 10 don't have an IT person on staff. So they have nobody in-house with digital expertise capable of monitoring this very important verify exercise. And it tends to fall to the practice manager, who may be a receptionist of 20 years experience that's grown up through the ranks, might be a financial accountant person managing the financial records, but they're generally somebody who's not, their primary purpose is not verification of trustworthiness. The tools that they use tend to be very simple as well, in as much that they're just looking at whether or not somebody has access information for longer than they should. If you think about that, I'm not really sure that's an appropriate level of fidelity around that access rights, because it doesn't take much time to have an inappropriate breach. In addition to all of that, a surgery will use a number of other tools and apps for patient digital engagement. And that makes it good for the surgery to have, prioritize their efficiency, frankly, over patient time, because it can actually drive a complex multi-channel patient experience. And that's something that we're beginning to see happening more and more as more and more apps come out for more and more of the services that are there, a specialist app for this, a specialist app for that. And it's the battle that the NHS is sort of theoretically going to take on with the NHS app, which is always tomorrow I'll do everything, but today I'm just doing this very small bit over here. So there's some interesting and very significant challenges in the model here. I'm not saying it's wrong. I'm just saying, let's just throw it out there as a point of discussion for trust management, and whether or not we can do better. Because the consequences of this are potentially significant. I mean, first of all, we've increased the attack surface for a phishing attack and insider attacks. And if they do get in, all the records of that GP surgery for all of their patients are potentially breached. So there's no context for, that person caring for that person, that set of records being breached. It's actually, you get into one, you got them all. Also, based on the information we got, talking with people who were there as they transition from paper-based systems to digital ones, is that, you know, the paper-based information was not just translated into the digital system, it was summarized. And there are many, many reasons for that. Some of the reasons were just handwriting. Some of the reasons were down to the level of rich patient information that didn't want to be shared because it wasn't assumed to be something that the patient had access to. Some of it is down to the complexity of the information in terms of potentially confusing patients. There's a wide range of issues for that. But now what we're seeing is that there's been a gradual shift in the way in which that information is being formalized, and trying to make things more efficient by templating the content, for example, making it really quick and easy. Yes, I did this, this, and this, tick box. I've gone through the care pathway and I've done the appropriate next step. Bang, 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 and that just gets summarized into a patient's record. Is that good for the patient? Is that what they're looking for? Are we losing some of that rich data as we do that, as we digitize our systems? Particularly if you think about sharing the information with patients so that they can better manage their care. I mean, I often say that the most under-provisioned person in health today is the patient. We're not doing enough to empower them and support them as they manage their own care, which they're doing 100% of the time, and we're doing for a 10-minute consultation once every 4 weeks or something. And then there's the patient trust perspective. They don't understand digital systems. They don't understand how GPs operate. But if they did understand that everybody in the GP, including the person they rang up who answered the phone, has entire read-write access to their record, where do you think that trust imperative perspective would fall? Based upon our previous analysis of patients and their view of data, not in a very positive way. So there are risks in this sort of model. Now, ultimately, I think it's, you know, anybody building these digital systems, the key to any digital system, and privacy, confidentiality, and everything else turns to be encryption. And actually, it's not so much the encryption itself, but the management of keys for decrypting and providing access. And in our current systems, we kind of lazily just adopt an IT type client-server model because that's the one that's easily provisioned, quickly built, relatively broad understanding. And, you know, we've just got a whole industry that does this stuff, and they end up managing all the keys, which means they have access to everything. They end up being the ones controlling access rights through provisioning of opportunity for access within a subsystem. And the extent to which they can do that depends upon their understanding and depth of knowledge of the processes that are at play. What this means is that IT responsibility is being taken away from frontline staff, which is great because they're not experts. But is the patient aware that there's this trusted intermediary who's making these sorts of decisions, who has ultimate access to everything? Control has to be as per a defined process, where that's kind of good as well, because we want that defined process. But it also tends to mean that we might be in our systems constrained to human responsiveness. And the more we try to cut that out for efficiency, we tend to drive automation. Automation takes that personalization and human out of the loop, and we end up with a kind of very robotic kind of system, which patients start to get upset with. So there's some very interesting balancing acts around that aspect of things too. I've already mentioned that IT has to have access to everything, so that's kind of an interesting challenge. But there's also no patient empowerment or thought process around control of that information from their point of view. You know, how are we enabling them with the information that's associated with their care so that they can better manage their care? You know, just giving them visibility that we took care of them and that they've gone, you know, they got through end steps of a process, they don't even know what the process is, isn't necessarily that informative. It just says, this is where you're at. And we're not telling you what's next, because until you get a letter telling you what's next. So I think there's an awful lot of loss of information richness in the way in which we're building such systems today. How about think about it slightly differently? What about if we started thinking about peer-to-peer for the information administrative processes? We might keep client-server IT for the administration of accounts, because we want to keep that with a bunch of people who know how to administer it. But what if we took the informational content of the communication and started making that something that was controlled by the frontline clinicians and the patients, and that was actually between them as a technological approach. I think, and that, you know, subsequent key sharing is enabled by both patients and clinicians. So it gets to that control element, right? Do we trust our patients in that context? Very interesting. So what controls do you put on that? Should we trust our clinicians in that context? I think we should, but they would need some help to understand how to manage that process, and it puts an overhead on them. So perhaps they're not particularly keen on it. But I would argue that the confidential discussion that I have with a doctor in a private room is now being reflected in the digital model, because now the information flow is just between us, and in the extent it goes beyond that is constrained by those who understand the clinical process and understand the clinical demands. And perhaps if we're going to go digital with our systems, clinicians need to start taking some responsibility in that context, and not just treat back office staff as somebody to throw tasks to. I'd like to see some, hopefully we'll get some interesting debates and discussions around that later. So what this would ultimately mean is that while IT still administers the system, they can't see the content. So what's confidential and private between me and my doctor remains so. And once you start doing that, you reverse that process of taking the richness out of information, and you improve the confidence that we can start enriching that content in a personal way around the patient. So I think that's a different way of thinking about this digital information exchange. Not saying it is the definitive way of answering the GP question. I'm just throwing it out there as, let's think about that for a second. The implementation model for that would be end-to-end encryption as the most standard peer-to-peer encryption methodology. What's interesting about that is that pretty much any digital healthcare system I've seen using audio-visual requires end-to-end encryption for that confidential conversation. However, as we go digital and the consultation expands beyond the parameters of a 10-minute discussion, why is that information, using all these apps and tools that are out there that I mentioned earlier, why are they not using end-to-end encryption? Because they're just an extended part of my consultation, right? So that becomes problematic for me, as we don't, because why are we not thinking about that? And I would question whether or not the reasons for that is laziness, because we just build systems one way and that's kind of like how you do it, isn't it? It might be efficiency, because we see that as being something that we can hand off to the IT department and they'll just do it for us. Or maybe it's for usability, because we can pretty much do anything with the information anywhere at any time. And therefore we can build whatever nice interface to it as we like. We're not constrained by the control systems of the security architecture. So I would suggest that the fundamental difference between these two is that client-server models have evolved as a security model largely to protect the organizations first. The default implementations of these systems is all about making your company and the organization legally compliant, about protecting the organization, and it's really, it pushes away that relationship element, which I think the peer-to-peer model brings in, because it starts with understanding that the relationship is the first thing to protect. So I think that's a very different way of thinking about it when we push our trust model to the edge, our trust points in our digital system at either end in a peer-to-peer model, rather than this centralized model, which is organization first in its thinking. So just in brief summary, we've got the pursuit of organizational efficiency through digital, which is a good thing, which patients embrace. Doesn't have to compromise their confidentiality in the way that it currently does. I think there are new ways of thinking about how we can do that. The usability of such systems isn't just about the UI UX. It first has to encompass careful thought about that trust and confidentiality assurance. Otherwise, if we lose that, in a digital system, like I said earlier, once gone, it's gone, right? So it's not like an interpersonal relationship. It's not like the doctor and patient in a room. And I actually think if we can entrust that or enhance trust through that sort of peer-to-peer thought process around the management of information, we can actually enrich the consultation and the communication and empower the patient. If you go back to that health foundation statement right at the beginning, the things that patients are interested in, things that enhance their communication and empower them in the process. So that's my summary for today. Let's go on to questions. Yeah, so questions, please. Hopefully we'll get them in. Emma.
Hi. Fascinating talk, Geoff. Thank you very much for that. I mean, watching the digital service evolve over time since I became a clinician, it has been fascinating. I mean, I've seen it through from paper records, had to do some summarising myself at some point. And, I've seen, the roles evolve as well. So we've got more multidisciplinary teamwork going across organisations. It's less about one person looking after a patient on their own at this point. It's much more about how people interact and how the patient is the main part in that conversation. And it has evolved significantly over that time. So I'm just wondering how you'd manage that with sort of the key-based system. How do you share those keys over multiple different users, and what happens if the key gets lost?
Okay, I'll do it in reverse. Key gets lost scenario, that can be managed by those that have the keys in a peer-to-peer model. So you've got a peer model for recovery, or if that fails you as well, then a such encryption model, because there's literally nobody who has access to the keys, has to use a break glass mechanism to recover the secrets that allows them to recover the system. And the right way to do that is to use something like the Shamir's algorithm, multiple people who have to coordinate together. And if enough of them do, then you get access to the key. And if they don't, you can't get access to the key. So kind of a 3 of 5 or 7 of 10 or whatever it is you want in terms of how that key gets reconstructed and shared.
Yeah, quite complicated in an emergency setting, but I imagine there's workarounds around it.
Yeah, I mean, you'd have to make that a manageable process. It's not actually that difficult. You can digitize it. We've already got in our system a simple web interface that allows that. Okay. So it can be done quite quickly, but it shouldn't need to happen except in a long series of extreme circumstances. Let's put it that way. You shouldn't need it. Coming back to the other question, yeah, there's a whole bunch of stuff that I really didn't have time to talk about in today's talk, but I think at the moment, part of the reason that we are challenged and end up giving everybody access to everything is because we don't know enough about what the roles are within our organizations, what the appropriate data access limitations should be for those roles, nor do we have enough classification within a large organization like the NHS around the data sets to fundamentally understand how they connect with or shouldn't connect with individual roles. So I think there's definitely some interesting work to do around those things, which is why we focus just on the consultation, because we can't, if you look at the whole of the NHS, you've just got a virtually insurmountable problem. If you break it down and focus on a particular area, then you've got an opportunity to consider that.
Okay. I know there's a lot of work going on role-based access, and there's the sort of NRL type databases trying to connect all the data up together. So a lot of that sort of will fit quite well with your model. There's a question in the chat. Is it more difficult to explain the technological processes to patients as opposed to other healthcare processes?
I'm not sure I understand the question. Let me see if I can interpret it. Is it inherently more difficult to explain technological operations to pro as opposed to other health? I think he means as in a peer-to-peer model as opposed to another model. So the short answer is no, it shouldn't be. in as much that from the patient perspective, they see no difference. And in fact, you will get closer, I would argue, to their underlying assumptions of confidentiality, privacy, and trust than in the current system, which if a uninformed patient was fully aware, they would be somewhat more concerned than perhaps they are. I think that might account for that sort of, at best high 40s, low 50s that do trust the systems, because they actually do have some idea of how disconnected their expectations of real world trust are to digital systems implementations of trust. They wouldn't probably articulate it that way, but it's kind of a gut thing, isn't it? Right. So I don't think you need to explain the technological processes to patients. I think what's interesting as an opportunity that would come as a subsequent and future exercise of a peer-to-peer model is that the systems that you put in place to facilitate an organization administering access rights and controls, a limited subset of those could be enabled for a patient so that once information is shared with them, they also have rights to subsequently share. The value of that, I think, is potentially huge, because at the moment, as we go through public-private care systems, the only way that you can actually initiate a system process at the moment is through systems integration first, process development second, and then devolution of service third. Whereas if you start patient-centered and empower them, you have an opportunity to start the process earlier with the patient initiating the access to information around them, because they have as much control of it as the organization does. And ultimately, it is their health data. And if you're going to empower people with their health data, how are you going to do that and allow them to do that while sustaining confidentiality, right?
It would certainly be an education.
But that's, I would very much like to say that's future, right? Don't even go there today, but I think it's a very interesting thought process for sort of 10 years down the road.
Yeah, I think trying to get people to digitally engage across the whole of the NHS is also quite complicated. So it would definitely be something we'd have to really think about how to do that.
Yes.
That was another question in. So regarding the technical aspect with the current client server architecture, do you think how challenging it is for the organisation to implement the mentioned security approach?
It is very challenging. We've spent the last year trying to get organizations' heads around it. And what we've discovered is that if you think about it, we've taken a patient-centered approach. And while organizations and clinicians claim to be patient-centered, it's the clinicians that are patient-centered, and the organization's digital systems, I would argue, are organization-centered. And we're not going to get to a world where people are empowered with their information until we really start to think patient-centrically. So we are finding that as an innovator, that we are having to find what I would call early adopters who get it and go, you know what, that's a better world, right? I can see a better world for information, and we need to think how to approach that better world, because the current model is not in favor of that. So yes, it's very difficult. I think our challenge, if we talk about specifically Safe Space One and what we're doing, is what we realize is we've got to figure out how to make the organizational management of the system as similar to their standard IT practices as we possibly can, because that's how you grease the skids for adoption. Is if it doesn't look or feel different in most terms, with only a few areas that are significantly different, then I think that changes things. And I think the second element is the clinicians have to get on board, right? Because we need better understanding as the extent to which they are willing or able to take some degree of responsibility and control for access rights or for information. And where and how far should that go, right?
Yeah.
Because they do have to empower the organization as well. And the easiest way of doing that is give them access to everything, but actually that's not necessarily the right thing to do for all information all of the time.
I mean, there's some cases are quite difficult with different patients. They have lots of team members involved with their care. There may be situations where they don't want to have a particular clinician or worker involved with their multidisciplinary team, which may impact that team working on where they need to go with that. Or there may be mental health aspects. So when you've got these keys being shared amongst team workers when the patient's not there, how would you manage that?
So when we started building this, our initial market focus was mental health. We then eventually discovered that actually structurally and architecturally what we were building was something that would apply to any long-term care need. And mental health is just a special case of that. And it has some very, very special case elements to it, such as the right of the organization to take power and control away from the patient, literally, and treat them as in the same way we treat our prisoners in some ways, but much more benevolently, for their own safety. And yeah, there are what you'd need to build. So what you have to build in, what you're talking about is what I would call the exceptions, right? So in this model, you have a generalized model and say, this is how we do it. And then you have to pick out those exceptions and go, right, okay, this is an exception. How do you deal with that? And what I can say is it's possible, but it is difficult. It takes a lot of work to think about it for some of those, what I would call exception cases. I think the broader question, or the broader answer to your question, is that it's very easy when everybody has access to everything to change processes inside an organization. And this would constrain that. So I think that there's a balancing act between those constraints and the trust of the organization and the patient of the system as a whole. And I'm not exactly sure where that is yet.
I was quite interested in your the research back there. Healthcare is more valuable than financial healthcare on the black market. Any thoughts on that? Why that is?
Why it is, yeah. So yes, the answer to why it is essentially that the black market is looking at not as the information as a sell many and multiple opportunity value set. So a credit card tends to be a one-use opportunity until the bank figures out what's going on and closes it down. So there's a limit. They could almost measure exactly what that limit is with respect to the value of that credit card. Healthcare information, as we saw when that mental health practice in Finland was broken into, the blackmail opportunity that they were able to derive from that information across a huge number of patients was huge. And that just taught the black market people that there was multiple ways of monetizing the information set. So it's about its monetization opportunity more than anything else. Intuitively you might go, oh, credit card, instant cash. Might be, but they're alive to that. Whereas there are so many ways in which the information of healthcare can be used and reused for monetary gain that it becomes a pot that you can keep going back to. Right. Let's say, for example, your DNA was accessed, right? So it's not just your DNA and as DNA processes evolve and we get better understanding of it, the ability to run those processes against the DNA set and say, oh, look, we now know that this person has a susceptibility to something, right? And we could blackmail them against that. But then, we also know that that's hereditary. So they've got, you can see on social media, they've got 4 kids. And so now we've got 4 kids we can go up. Do you see what I mean? It's just, you just can keep going at it. Yeah. That's why it's so much more valuable.
And some of the other research you had back there was about the trust in the digital sharing and of information. Do you think it is mostly about cybersecurity, or is it more about the fact that they can't quite see where their data is, or is it just generally an inherent don't want to share much further than what I see right in front of me?
So you're talking about the NHS study?
Yeah, trust issues can come in different ways.
Yeah, they do. They come in. That's why I kind of tried to go through trust in several different ways, because they do come in many different guises. So I think some parts of the needle are movable and some parts are not. So there was 10% of those people, as I remember it, who were just like, they start with no trust. You're not going to get my trust. That's it, period. They've had, probably due to some consequence that they've suffered at some point, that they've laid at some institution's door and they go, yeah, can't trust these people, right? It could be their socioeconomic background that drives that. It could be a particular experience. It could be both, a whole bunch of things. So there's a certain element of unmovable needle. Where, as I said, in the World Health Organization trust model, what I thought was really interesting as I looked around systems around the world that I've looked at, so let's take O2 as a big company example, right? They watched the big breach that happened with what was that other mobile operator? Began with a T. T-Mobile, I think it was. And subsequently, they came out with a big shift on, you can trust us, and our big focus is all around our client trust. And they went out totally on transparency, really clear on their transparency. They kind of assumed accountability, and they didn't give anybody control. But you go back to that Health Foundation research, and you look at that, and you go, well, actually, people want control. They want to be empowered. That is control. And they're not being empowered in those systems. So I think what you end up with is a world where businesses constrain themselves historically as to how much trust they're willing to trade for through implementing the trust model that would maximize trust opportunity. Do you see what I'm saying?
Yeah, absolutely.
But I think there's an opportunity in health to go much further than O2 and similar. Yeah. Because ultimately, as I said, I find it very interesting that we don't do as much as I think we could do in digital to empower people in managing their own care as part of our consultation process. And if we try to think creatively about that, then the resource problem that the NHS and all clinical service providers have around the clinical care could perhaps be alleviated, at least for the long-term care type people who, there is a pattern. It's not exactly replicated, but it kind of follows a similar approach. It kind of goes through a similar process. We know where they are in that process. We could advise them what's coming next. We could provide that information. We could guide them on how to mitigate or minimize those steps as an automated digital element of delivery of long-term care. I think by empowering people that way, facilitating a kind of long-term care prevention exercise in a way, help them by empowering them, then we change the equation on the cost of services potentially. That's kind of a longer-term vision. I think we at Safe Space One have for sure.
I'd be really interested to see how the end-to-end encryption will actually display itself as in that clinical setting, or when you're having discussions when the patient's not there. How would that work with the patient who's not in the room, or maybe when you need to talk to other colleagues for advice, all those kind of things? There's a lot of scenarios where
there's a lot of scenarios. So I think there's
have the patient in there. So there's got a lot to go through.
So that's where the trust model comes in to sort of help you. So a clinician sharing with other clinicians for the purposes of my care isn't something you need to come to the patient for. Transparency that you're doing it may or may not. So we actually went through an exercise on this one. So it may or may not be appropriate to be transparent as well. So for example, let's say it was a form of cancer, right? Or you don't even know it's cancer yet. You've got a melanoma or something that you're looking at, and you are now consulting with an expert in that and sending them, x-rays or whatever it might be that you've got, and samples for their analysis. Now, one way of being totally transparent is that whenever that transaction of information exchange happens, you tell the patient. You may not want to tell the patient until you've got the results. So maybe but sometimes the result isn't relevant. It's about, it would actually enforce the patient's understanding that you're working on their behalf. It would give them visibility that you're going out and consulting. So sometimes there might be a different part of the process where you actually want them to have that transparency. And the digital system could facilitate that. So that's why on our team, one of the people we've got is a sort of consent management person. And we spend a lot of time trying to think through, okay, when should consent be required? When should transparency be required? And when should transparency be delayed? And when should transparency not even happen? Because you've got to go through all of those stages to really figure out what's the right thing to do at the right time for different types of information flows, which comes back to why I said earlier, really need to understand information categorization as well as roles.
Yeah, it's quite fascinating. If you end up in a conversation where you are investigating, maybe you think they may have cancer, you talk to an oncology consultant, that comes up on your transparency feed. Yes, you wouldn't want that to go through to the patient.
No, you wouldn't.
At the wrong time, but you still want them to know that it's happened. So yes.
Yeah. So the fact that it's happened should be in the log, right? The fact that it's there, and at some point the patient should be aware. Because in many ways, that once you've managed their awareness, either that, sorry, you've got cancer, or by the way, I've checked and you definitely don't have cancer. Either way, at that point in time, the fact you consulted with somebody who you consulted with should be information that should flow back to the patient, and they should be empowered with. They can see that that you haven't just gone into this black hole of care and the GP is going to get back to you in 3 weeks' time. It's something was going on.
Yeah.
And you may not see it happening at the time, but the fact that you see it later gives you confidence next time you go to see that GP, that just because you haven't heard anything for a week doesn't mean they're not doing anything, because last time they told you afterwards that he did all these things. And you can see from the timelines, for reasons that are obvious to the patient, why they hadn't told you, but they did eventually tell you. Do you see what I'm saying?
Yeah. I mean, the number of conversations that will go on just to before you even get to any kind of decision or diagnosis. And I mean, all of those are quite complicated to really explain step by step to a patient. But I guess I'm imagining over time patients become more accustomed to that this is how we come to a diagnosis. It takes a while to get to decisions sometimes.
Yeah, but what I'm saying is, at the moment, all we know is, all the patient sees is a decision.
Sometimes.
A decision and a time delay.
Yeah.
Right.
Yeah, they don't know where they are in the process.
They have no idea where they are in the process.
Yeah.
And that's a very commonly vented frustration that we hear from patients, is that they're not empowered because they don't have transparency. Right? Yeah.
It's a very interesting slide. I really quite enjoyed the one with the trust, transparency, accountability, and control. We use that kind of discussions in clinic when people are stressed, and when there's work stresses, everything else going on. It's that similar kind of language of where those factors and triggers may be coming from. Yeah,
I mean, it's a basic trust model that's out there. It gets renamed slightly and interpreted differently, but essentially the structural model is the same for anything that's seeking to gain trust as part of an engagement.
Okay. All right, I haven't got any more questions in the chat. Is there anything else you'd like to share with us, Geoff?
No, I think that was, you threw a good few questions in there. Appreciate that. Thank you, Emma. And thanks to everybody that came online and listened in.